Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala Sayyidina Muhammadin Ashrafil Mursalin wa ala alihi wa sahbihi ajma'in. Assalamualaikum and greetings to all. My name is Dr. Azizul Hafiz and I'm currently working as emergency physician at Hospital Teluk Intan. I would like to thank you guys for joining in this Perak Trauma and Support Course 2022. Alright, so today we're going to talk about trauma in pregnancy. Why this topic is important. In general, we know that pregnant lady is put under special population. We categorize them as such because there are few anatomical and also physical changes that happens during the pregnancy. So the same concept can be applied to pediatrics and also at the elderly age group. Okay, so by knowing the changes, the significant changes that happen, it can help us in managing pregnant lady to give them a better outcome. So, for our objective, we want to look at the unique aspect of obstetrical trauma and how to approach the trauma in pregnant patient and what are the investigations that are required and what are the risks and benefits. And last but not least, we will talk about emergency C-section, also known as resuscitative hysterectomy. Whenever we're dealing with a pregnant lady, we must bear in mind there are the two patients involved, there are two lives involved, the mother and the fetus. Whatever it is, we have to give priority to the mother's health first. And we have to know what are the changes in maternal anatomy and physiological that happen. Okay. So how do I evaluate and treat two patients? For optimal outcome of mother and also the fetus, clinician must assess and resuscitate the mother first and then assess the fetus before conducting a secondary survey of the mother, which means that if the mother in distress and we didn't resuscitate the mother enough, the chances for the fetus to survive is minimum. Alright, usually the changes in pregnancy will be divided according to the stage of pregnancy, which are the first trimester, the second trimester, and also the third trimester. The first trimester that occur in the first 12 weeks of pregnancy. This is the most critical and vulnerable stage. Fetal cells undergo differentiation into specific tissues, and any trauma can cause spontaneous or threatened abortion. Beyond 13 to 28 weeks, which are the second trimester, this is the time that the fetus develop bony structures. There are facial features appear, and the uterus start to enlarge and is palpable at about the level of the mother's umbilical. And beyond 28 weeks, we are the third trimester, the uterus reaches its maximum expansion, pushing into the mother's diaphragm and thoracic cavity. Therefore, trauma to the gravid uterus can lead to serious complications. In case if we don't have enough information in regard of the gestation of the fetus, we can always estimate the stage of pregnancy according to the fundal height. If you're able to palpate the fundal height at the area of the symphysis pubis, then the pregnancy is around 12 weeks or the first trimester. And we're able to palpate the fundal height at around the umbilical, then it's around 20 weeks. And then around, if we can palpate the fetal height at the upper abdomen, means that it's already in the late pregnancy, maybe 36 and beyond. So what are the anatomical changes that happens during the pregnancy? First, because of the increasing size of the fundus or the uterus, there will be elevation of diaphragm and abdominal content are pushed upward. Therefore, if there is any injury to the chest, we must also suspected as possibility of intra-abdominal injuries. The bladder will be pushed anteriorly and superiorly. Therefore, increase the risk of bladder injury. And the IVC will be compressed by the uterus, reducing the venous return, and this will cause maternal hypotension. And the stretching of the symphysis pubis and the sacroiliac joint ligament, because increase in the elasticity of the tissues, that they will cause false diathesis picture in X-ray of the pelvis. So when we look at the physiological changes, for the respiratory system, there is higher basal metabolism. The oxygen are required more, about 20 to 20 higher in comparison to the pre-pregnancy state. And there also a physiological hyperventilation, whereby the tidal volume is slightly increased. And this will lead to respiratory alkalosis. In normal population, the partial pressure of carbon dioxide is about 35 to 45 millimeter mercury. But we take a lower, the normal level for partial pressure of carbon dioxide in pregnant lady is lower, which is 25 to 30 millimeter mercury. And then in regard of the cardiovascular system, the blood volume or the plasma volume is increased by 50%, and the red blood cell increase is not as much. Therefore, the sign of hypovolemic shock appear late. Once it happens, it means that a very significant blood loss have already occurred, and the conjunctival and the neck beds normally is vasodilate. Our physical examinations to look for pallor are unreliable sign for the loss of blood. And then because there is placenta and also increase the blood flow to the pelvic region, the pelvic fracture can result in severe blood loss. When you look at the gastrointestinal tract, the gastroesophageal junction become lax because of the hormonal changes. The gastric motility and also emptying time is increased, and also there is increase in the gastric juice secretion. Therefore, we shouldn't assume that the stomach is empty, and then we need to insert nastrogastric early to decompress the bowel and also the stomach and to prevent aspiration. For the genitourinary tract, the fetus is cushioned by the amniotic fluid. Any injury to the abdomen can have the risk of amniotic fluid embolism, which can lead to DIC. And then at the late stage of pregnancy, the fetal head is within the pelvic cavity. If any injuries to the pelvic, this may result in the skull fracture of the fetus, which carry a poor prognosis. This table shows normal laboratory values for pregnant versus non-pregnant. Hematocrit in pregnant lady, they are lower because increase in the plasma volume. White blood cell is increased slightly. And because of the changes in the respiratory system, the arterial pH is slightly alkalotic, 7.4 to 7.45. So the bicarbonate is reduced because as a compensatory mechanism, and the partial pressure of carbon dioxide is also reduced. The fibrinogen for pregnant lady is increased, especially at the third trimester, as the body prepared for delivery. So therefore, the fibrinogen increasing, and the partial pressure of oxygen in pregnant lady is higher compared to the normal population. Okay, so whenever we're dealing with episode of hypotension, patient who are pregnant, then we have to think about supine hypotension syndrome that usually occur after 20 weeks of pregnancy. So in supine hypotension syndrome, the gravid uterus, the enlarged uterus, is compressing on the inferior vena cava. Therefore, we reduce the venous return and also the ejection fraction. So how to treat this condition? Actually, basically, we have to displace the uterus to the left side. There are two ways. You can use the hard wood or hard item and place at the back of the patient, such as a spinal board, and then you can put something such as towel to tilt the board in about 30 degree. Okay, so this will displace the uterus to the left side. Okay, or you can manually displace the uterus using your hand to the left side of the patient. So by doing this, actually you can increase the venous return up to 30% just by a simple maneuver. So let's go for a case example, case 1. Patient, 25 years old woman at 26 week, came following a motor vehicle collision. She is unconscious and immobilized on the spinal board. the patient in high flow mass 15 liter per minute, GCI is 7, BP is 110/50, and the heart rate is 130 beats per minute. The respiratory rate is 28. How do we manage this patient? So to manage this patient, actually the flow is not much different from non-pregnant patient. We do the primary survey to look for the life-threatening condition, and then according to the airway, breathing, circulation, disability, and also exposure. Okay, so in this patient, we notice that the patient GCS is 7. All right, so it's one of the indication for intubation. Okay, so if we want to intubate the patient, well, we might consider a few things. First, there are features of difficulty in managing the airway in patients who are pregnant, such as the short neck, the larger chest, and then the airway is edematous. Okay, so more prone to injury if we don't do it correctly. Okay, to prepare the patient for intubation as well, we must consider the risk of patient become hypoxia because there is reduced oxygen reserve, and there is risk of aspiration because of the lacks of the gastroesophageal junction. Right, so we might want to complement, apart from high we might want to upgrade with the Beckma valve or together with the nasal prong for optimization for pre-oxidation, and then we can give IV Mesalon before we intubating the patient to prevent for aspiration. Okay, and if we have the chance to look at the ABG, we expect the normal pH in pregnant patient should be slightly alkalotic in a respiratory alkalosis. So if the PCO2 is normal, maybe a sign of impending respiratory failure. Okay, so if you want to put a chest tube in, we know that the left uterus is displacing into the diaphragm, and then we need to put the chest tube at the one intercostal higher than usual lah, at the fourth intercostal space. Okay, for the circulation, hypotension, tachycardia is a late sign. This is because of the increase in the plasma volume. Therefore, we have to turn the patient to 15 to 30 degrees to the left, either by using a spinal board or you manually displace the patient to prevent supine hypotension syndrome. Okay, so let's say this patient having a fit. While you managing the patient, this patient having a fitting episode, you have to treat the fit. Okay, and then you have to think of possible of eclampsia. Okay, so look at the BP. If the BP is significantly high, it might be eclampsia, and then you can check for urine protein as well. And then for exposure, we do the log roll, and then we have do the perineal examination lah, to look for any blood, any wound, we not sure any fetal head there. So there's a extra examination that we need to do. Okay, and then after that we proceed with the secondary survey. Okay, so we start with focus history, the ample. Okay, and then we do a rapid head to toe examination. Okay, and then we can refer to our ONG colleague for them to do prespeculum and also vaginal examination, their formal obstetric ultrasound, fetal heart rate, and also cardiotocography. So in regard of this patient, the patient was intubated for airway protection. Okay, the uterus was displaced to the left, but the patient did not respond to the fluid resuscitation, and then a fast scan shows there is an intra-abdominal fluid. Okay, she was given resus immunoglobulin therapy and antibiotics and was taken emergently to the operating room. The patient underwent emergent splenectomy and an intraoperative cesarean section was performed. After that, she underwent a CT hit post-operatively, which identified a small intracranial contusion. Okay, she recovered after a prolonged intensive care unit course and was able to go home to a healthy baby boy. Okay, so what are the clinical issues involving traumatic pregnant patient? So one of it is a rhesus negative blood group. As little as 0.01 ml rhesus positive blood will sensitize 70% of rhesus negative patient. Therefore, all pregnant rhesus negative trauma patients should receive rhesus immunoglobulin therapy unless the injury is away from the uterus, such as in the case of isolated distal extremity injury. Okay, and the immunoglobulin should be given within 72 hours of injury. They also issue regarding the radiation from the imaging. The radiation risk to fetus are related uh, to the exposure, magnitude, and also the time of pregnancy. Radiation risk most significantly occur during organogenesis, which are actually at the second to the 8th week. And then the exposure magnitude, if the exposure is 100 to 200 milligray, the risk of malformation is there. And if uh, the exposure magnitude is around 100 milligray, there is a risk of mental retardation. Okay, so this table shows effect of gestational age and also the radiation dose. All right. So if the exposure of the radiation happens during 0 to 2 weeks after fertilization, so the effect can be either death of the embryo or there is no consequence, right? And the threshold is estimated around 50 to 100 milligray. Okay, but during the organogenesis, okay, this is where the period of critical, where the patients, where the fetus actually undergone cellular replication. So there is higher risk of congenital anomalies, which can be the skeletal, eye, or genitalia, and also there is also risk of growth restriction. Okay, so but the magnitude or the exposure level is higher. It's around 200 250 milligray. Okay, so but after that, after beyond that, around 8 to 15 weeks. Okay, so usually it's related to the severe intellectual disability lah. Okay, but we can see the threshold is also getting higher. All right, and then during 16 to 25 weeks, okay, the effect is much lower lah, and then the magnitude also required to have the effect is higher. Okay. So how about CT abdomen? So if you have a concern uh, regarding intra-abdominal injury or any other indication that you want to proceed, you think you need to proceed with the CT abdomen, so it shouldn't be a problem. It's because an abdominal or pelvic CT scan radiation dose approaches is about 20 milligray. Okay, and the fetal radiation doses less than 50 milligram are not associated with the fetal anomaly or high risk of fetal loss. Right, so it's safe to do a CT abdomen in pregnant patient. So this timetable shows the amount of radiation to fetus from X-ray examinations during pregnancy. Right, for example, if you want to order chest X-ray for a patient, it's actually very minimal, 0.01 milligray or less. And plain abdomen is 1.4 milligray or less, and lumbar spine is 1.7 milligray. All right. So CT, which are higher exposure, okay, the highest we can go when it happens in the pelvic lah, right, at the pelvic area, but it's only 25 milligray. As we recall from the previous timetable, for to have a congenital abnormality, is required the threshold is about 200 to 250 milligray, right? So it's rather safe to do. It is safe to do a X-ray in pregnant patient. So we move on with our second case. 20-year-old female, 30 weeks gestation. She was struck by a truck across the street from hospital. Okay, so the accident happens near the hospital. After that, she experiencing cardiac arrest, and the paramedic have intubated and started CPR. Downtime is about 5 minutes. On arrival, you notice that she has PEA. How should we proceed? So, of course, you have to continue resuscitation the patient. Okay, you can initiate the red alert, call for help, get more people involved. Right? Do a repeat and primary secondary survey. Okay, and you have to try your best to find the reversible cause of the PEA. Okay, so what should you consider? Okay, when should we consider emergency C-section, and how much time do we have if we want to perform the emergency C-section? What about premotum C-section? Right, so when should we consider premotum C-section? In any pregnant trauma, if we think that pregnancy is more than 20 weeks, then we should consider premotum C-section. Okay, if you don't have the exact info regarding the gestational age, then you can try to palpate the fundal height. If it's uh, more above the umbilical area, then it's more than 20 weeks. How much time do we have? In the cardiac arrest situation, every attempt should be made to consider cesarean delivery within 4 to 5 minutes of arrest. Right, so it's a rather a quick, fast decision to make. Why perimortem C-section? Okay, so CPR alone is inadequate during pregnancy. Right, so you have to consider premotum C-section in cardiac arrest pregnant women. Okay, and they have less reservoir of the oxygen, so the apneic pregnant woman become anoxic much quicker than the non-pregnant woman. This can lead to irreversible brain damage that occur within 4 to 6 minutes. However, most of the literature are from anesthesia-related cases. Okay, so this table is actually can be used as a guide when we managing a patient, a traumatic pregnant patient. So if the patient tend to be hypotension, and then gestational age is more than 20 weeks, and don't forget to put the patient at the left lateral decubitus position. Okay, but you still have to look for other causes of hypotension. If there are evidence of bleeding or hypovolemic shock, you can initiate your resuscitation with IV fluids, but you need to transfuse the patient early. Okay, if the blood pressure happens to be high, okay, so you have to think about eclampsia or pre-eclampsia. Okay, if the gestational age is more than 20 weeks, okay, so the patient, so the baby need a fetal uterine monitoring. All right, if in district hospital where you don't have your ONG specialty, then you need to refer, stabilize the patient and refer. Right, same if the patient having a vaginal bleed. Okay, treat the hypotension and then ONG consultation, and don't forget about rhesus negative immunoglobulin. Okay, for the lab test, in addition to other usual trauma studies, okay, uh, forget about the CBC, the first test. Okay, usually low hematocrit, usually we expect that to see in a pregnant lady. Is the type screen PET scan test. Okay, so this test actually want to detect for fetal maternal hemorrhage. Okay, so if the mother is rhesus negative and the fetus is rhesus positive and happens to be there is a fetal maternal hemorrhage, the test will be positive. Okay, but the problem is the threshold for it to be positive is the amount of blood of the fetal blood must be more than 5 mils. okay, ataupun at least 5 mils in the maternal circulation for the test to be positive. Okay, but we know that it only take about 0.01 mil of the rhesus positive fetal blood. Okay, so if the test came back as negative, you still cannot rule out fetal-maternal hemorrhage. Okay, so you still need to give RH rhesus negative immunoglobulin, right, in the patient who are having a rhesus negative. Okay, other than that, for the collagen profile, we can look at the INR, PT, fibrin degradation product, fibrinogen, or the cum test. Alright. And then for the diagnostic imaging, alright. So the order for the same general indication as for non-pregnant patient. Okay, so there's no difference. We have to coordinate with the radiologist and consider ultrasound to replace X-ray whenever possible. Okay, so also whenever possible, use a shield to protect the abdomen, pelvic, and the neck. Right. Okay, we continue with our bedside tool. Okay, RH negative, I already mentioned. The dose will be a 300 gram IM. Alright, don't forget about your anti-tetanus, which are safe in pregnancy. And if the BP is high, systolic more than 160 and diastolic is 110, so we can give labetalol 10 to 20 mg IV. If the patient having a seizure, if the seizure is because of the eclampsia, then start the magnesium sulfate. Right? If you're non-eclamptic, you can treat as usual by giving a benzodiazepine as your first line. If the patient is in cardiac arrest and is more than 20 weeks, you have to continue resuscitation. Okay, and the patient should be put in the left lateral decubitus position. Okay, if there is no return of spontaneous circulation after 4 minutes of CPR, you should consider cesarean delivery of viable fetus. Okay, so we go to the last slide. Okay, so this is the treatment medication listed, which are usually commonly used in pregnant traumatic patient lah. Alright, so for IV fluid, patient require larger fluid requirement when hypotension. Avoid dextrose D5 loads. I think we are familiar. We never resusc patient with a D5. Okay, with the hypotonic solution. So oxygen, okay, to avoid fetal hypoxia, administer high concentration of oxygen. Intubation and rapid sequence intubation. Indication for procedure are generally similar to non-pregnancy, but we have to anticipate difficult airway intubation. Analgesia used as needed and inform ONG of doses and times if fetal delivery is anticipated. Right, for antiemetic, okay, we can give metoclopramide and also ondansetron. All right, and also antibiotic, IV cefuroxime. Okay, for the conclusion, the key point here is we have to know the physiological and also anatomical changes that happen during pregnancy. Okay, by knowing these changes, it can help us in resuscitating the patient. Okay, and please refer to the surgeon and also the ONG team early, right? We want them to co-manage the patient ataupun to resuscitate the patient. Okay, assess and resuscitate the mother first, and then assess the fetus before conducting a secondary survey of the mother. Okay, all pregnant rhesus negative trauma patients should be receive rhesus immunoglobulin therapy. Okay, unless the injury is away from the uterus. Okay, and then the emergency C-section should be initiated within 4 to 5 minutes of cardiac arrest. Okay, I think that's all for my presentation. Thank you all for your time, and I hope you learned something today. Right. Thank you and Assalamualaikum.